So I actually was here yesterday and was really impressed by the panel discussions also, and actually the arc of the discussions from the morning to the evening paralleled, it actually anticipated many of my points. We went from discussing the pharmacological properties of opioid antagonists and agonists to the complexity of accessing these medications in a fragmented healthcare system, and then to the importance of addressing stigma, trauma, fostering peer support, community connections, and meaning when it comes to even medications. So I'm going to very briefly try to present some of my research as, first of all, a board-certified addiction psychiatrist still working at Bellevue in their outpatient chemical dependency program, and where I've been for over a decade. Also as a cultural anthropologist studying the social and cultural context of the current crisis and what led us here. Three major points. The apparently universal nature of the current crisis is the product of specific ethnic marketing of opioids and targeting of drug regulation to white consumers. Second, the impact of the opioid crisis on whites opens a window of opportunity to address the social determinants of health, but only if we directly address racial inequalities. And then third, in order to see population benefits from addiction medications, we have to foster social and structural change. And that's where I think the panels from yesterday really anticipated this discussion. So my research, let's see if I can change slides. Okay, so my research actually was prompted by my direct clinical observation of the pattern captured in this really early CSAT study, and that we continue to see today in most parts of the country. According to the congressional testimony leading to Data 2000, which legalized office-based treatment of buprenorphine, buprenorphine was introduced to meet the needs of, quote unquote, a new kind of addict, one that was, quote, suburban and, quote, not typically associated with the term addiction. So implicitly white. Deregulation of buprenorphine and the marketing and media surrounding it, which was coded as white, and these are just some images from the manufacturer's website. These were intended to destigmatize opioids and addiction treatment. But addiction has long been enmeshed with race in our American policy. A century ago, racial imagery was used to build support for narcotic prohibition. And let me just, okay, there we go. Later, racialized images of heroin justified the war on drugs under Nixon in 1971. And then racialized symbolism of crack, cocaine, reinvigorated the drug war in the 1980s to 90s in the midst of record unemployment in black and brown inner cities, prompting racially disparate law enforcement and mass incarceration instead of a public outcry over the tragedy of drug-related deaths. At the same time, as historian David Hirschberg shows, there's been a separate track of legal protected narcotics for use for middle-class whites for over a century, and it has long been lethal. Overdose among largely middle-class white women from barbiturates in post-World War II era rivaled opioid overdose deaths today. Later, benzodiazepines like Valium were marketed as mother's little helper to suburban white middle-class markets. And our current opioid crisis was fueled by targeting marketing of OxyContin and other newly patented opioids to predominantly white, rural, and suburban areas for a large new market of moderate pain, people with moderate pain like lower back pain that traditionally had been, where opioids had traditionally been restricted to post-surgical pain and cancer pain in their use. So they were marketed in populations whose race did not trigger regulatory surveillance due to their assumed lower risk of addiction. And this led to non-medical opioid use in suburbs and small towns previously isolated from port city-oriented heroin trade. And after restrictions on prescribed opioid supplies through prescription drug monitoring programs and other new opioid formulations that were difficult to inject or snort were introduced to the market, this brought heroin to suburban and small town markets. And that's where these two images that I'd flashed earlier come into play, the new face of addiction. And then, as you know, fentanyl accelerated multiple overlapping opioid epidemics. Black middle-aged men are now showing the fastest growth in overdose deaths, Native Americans show twice the overdose deaths as whites, but the epidemic is still seen as disproportionately affecting whites. So I'm going to go forward to this. Okay, this is probably a study that's very well known to all of you. This perception of the opioid crisis as affecting whites was made explicit when two economists sounded the alarm of population-level decline in life expectancy, specifically white life expectancy, largely due to opioid overdose deaths. And they coined the term deaths of despair, referring to the post-industrial decline of the white working class in the Rust Belt. And it's blamed for opioid use, overdose deaths, and suicide as the social fabric disintegrated in these areas through unemployment. Because the focus is on whites, the logic of social determinants of addiction can finally be heard in drug policy, yet the same argument could have been made for the black working class that also progressed from industrial divestment and unemployment to opioid deaths decades earlier. So in our era of neuroscientific understandings of addiction physiology, it's tempting to forego attention to social determinants in our longstanding search for magic bullets in order for medications to have population effects, though. This is really my argument. The social and health systems in which they're used has to be foregrounded. So let's take France, which is often held up as a success story of buprenorphine maintenance as overdose prevention. In France, the opioid overdose rate dropped 80% in the first 7 years after buprenorphine's introduction into primary care. It was billed not as a stigma-reducing agent for a white middle-class market, but actually a public health intervention to stem overdose and HIV transmission in low-income, largely immigrant heroin-injecting communities. In a country with universal health care and a robust social safety net, and I have to underscore that, universal health care, robust social safety net, very different context. So contrast this with the US, where the overdose rates more than doubled in the first 10 years after buprenorphine's approval for office-based use. The public health potential of buprenorphine is limited by our race and class segregated healthcare system, which orphans patients that have patchy insurance coverage and tenuous access to prescribers. So the bottom line is that we have to intervene on social structures, race and class-based inequalities in order to see public health impact of medications for addiction. Thank you.